So thank you very much, Bob, for this kind presentation. I'm very happy to have received this award. I'm not totally sure that I can really deserve it, but in any case, I am extremely happy, and thank you to all of those who have contributed to this achievement. So today I will talk a little bit about what we can expect beside, I would say, TKI therapy for CML patients in order to target the CML leukemic stem cells. Why this? We know that indeed, these are my disclosure, fortunately. We know that TFR is the ultimate goal in our years of the CML therapy. But what have we learned about TFR in the last 10 years? I would say certainly TFR is possible. We do not know if this is a real cure, but it's certainly something which is very similar. And trying to achieve TFR is substantially safe because out of many patients that have tried to discontinue the TKI therapy, the number of progression are really few. And to go deep, fast in molecular response and to stay in deep molecular response for a longer period of time is always better. And starting from this point, I would like to recall that is a slide which was part of a work of our Australian colleagues, showing clearly that even in the best possible conditions, patients who are achieving a deep molecular response very, very fast within a very short halving time, with the ideal type of BCR Abelson transcripts, very, very long follow-up and very long deep molecular response. However, maximum, the percentage of successful TFR can be observed in 65–70% of the patients. So my question is, if the highest chances of a long-term TFR are maximum 70–80%, which are the biological factors that can hamper a successful TFR? And we know that there are at least two different aspects on which we have to work. One is maybe the clonogenic potential of the residual leukemic cells, which may have some form of hidden, if you want, resistant to the TKI therapy. And the other, and we will not talk about this today, is an immunological control on residual leukemic cells. We started, however, working on the first aspect, the clonogenic potential of the leukemic stem cells and their survival, from an assumption that the TKI therapy alone will never be able to do the complete job in eradicating leukemic stem cells, because in most patients they are resistant, and even after therapy discontinuation, they can resume the leukemic process. So in which way we can aid these resistant leukemic stem cells in a different way? Our group has tried to develop two different approaches. The first one is based on the phenotypic differences which are indeed presented by the leukemic stem cells with respect to their normal counterparts. One of the best markers is centrally represented by these CD26 positive cells, which has been in particular studied by the group of Peter Vallen. And as you may see, newly diagnosed patients with CML, they show a high percentage of the CD26 positive cells, both in the bone marrow and the peripheral blood, and this, of course, in the progenitor fractions like CD34 positive, CD38 negative, or CD34 positive, CD38 positive, however, much more in the CD34, CD38 negative. These are absent apparently on healthy donors, on the CD44 positive cells of healthy donor, but we can see that in case of resistance, also CML patients, they have an increase of the percentage of CD26 cells. So we have exploited the fact that there is a human antibody, which is monoclonal antibody, which has been indeed developed to target directly the CD26, is already clinically available as begelemab. It is used as an agent against the acute graft versus host disease. And we have indeed loaded this antibody on the surface of a liposome. And this was not an easy work at the beginning, I would say, but indeed we succeeded at least, and we had what we call an immunoliposome. And this immunoliposome was indeed shown to be specific or to target specifically the leukemic stem cells with respect to what we observed in the normal stem cells. And is another point which is extremely important, that when we loaded this immunoliposome with venetoclax, why venetoclax? Venetoclax because, as you know, is an anti-BCL2 drug which has been shown to be active in CML. Indeed, there are also clinical trials running the combination of TKI with venetoclax. Indeed, what we have seen that immunoliposome with venetoclax was able to significantly induce apoptosis and the cycle arrest in CD26 cell lines. And what is also important, that even more important, I would say, that this was also clearing ability was also seen in primary CD34 positive cells from CML patients. As you may see here, this is before and this is after the treatment. There is in all cases a clear decrease of the number of the CD26 positive cells, as well as the same happened indeed in the CD38 fraction, although in a, I would say, a little bit less specific manner with respect to what we see in the CD34, CD38 negative fraction. So we are waiting now to finish the work with this approach, but we started simultaneously another approach, which was based on metabolic differences between leukemic stem cells and normal stem cells, starting from preliminary considerations that when we have an expansion and progression of a clone, indeed, clone of leukemic cells, indeed, these cells require to rewire their metabolic state and also to increase their energy production. The adaptation is mainly managed by the mitochondria because these are the pivotal metabolic organelles of each cells. And the level of nucleotide production for fast proliferating cells may be sometimes become insufficient, and they have to fulfill the needs of I would say, pyrimidines and purines via de novo pathways. Elevated activity of de novo pathway may reveal a vulnerable side of the leukemic stem cells. So starting from the consideration, we considered that to inhibit this enzyme, which is the dehydroorotate dehydrogenase, would be something of importance for the maintenance of stem cells and by trying to eradicate stem cells. Why? Because this enzyme is able to transform the hydroorotate to orotate, and this is the basis just for the pyrimidine synthesis, uridine, and which are essential for the synthesis of the nucleic acid, of course. So they are proliferating cells are in high need of these components of the nucleic acids. So the ODH is a vital enzyme for the de novo pyrimidine synthesis. And indeed, it has been already demonstrated that inhibiting with a DH inhibitor like Brekinar, DHODH, we are able to unlock the differentiation block in AML. A potent DHODH inhibitor called was on the same time developed by chemical pharmacology of the University of Turin. And therefore, we work mainly with this new agent. We work with this agent, which is called the MATS 433. And inhibiting the DHODH, we were able to show that this induces cell cycle arrest and suppresses the growth of leukemic cell lines and also of leukemic stem cells from newly diagnosed CML patients. So these are several, I would say, cell lines, and these are positive cells from patients. And the same cycle, as we will see in the next slide, and also the inhibition of the AHODH induces apoptosis in CML lines, as well as again in leukemic stem cells from newly diagnosed CML patients. What is interesting to see is this effect is definitely more pronounced on primary cells with respect to what we see on cell lines, in which most of the cells indeed are entering apoptosis with a concentration also low of 1 micromolar. And this activity continues, of course, against, or is shown also against resistant CML stem cells from resistant CML patients. This is very important because it tells us that probably we can overcome all forms of resistance of these cells. One way to demonstrate that these effects were really due to the use of DHDOH inhibitor is that using uridine, so the final product, we are able to overcome this block effect. And indeed, using uridine, as you may see, we are not obtaining an effect that is obtained by the concentration of the inhibitor alone. These are experiments on the cell cycle, and which are telling us that the cell cycle arrest appears on the SG2M phase, both in cell lines as well on primary cells. And this is another interesting experiment in which we have, I would say, mirrored what is happening in the bone marrow niche by using this bone treated with collagen. And you may see that indeed that this is the empty bone, the substrate, we can say, and then we have the growth of mesenchymal cells on it. If we had the CD34 positive cells from CML patients, we are seeing a great proliferation of these cells. If we are adding on the opposite, the HDOH, the proliferation is blocked. So this is an important experiment that mimics what is happening, can happen, also in vivo system. Then we tried to understand the mechanism through which the molecular mechanisms, the molecular pathways which are involved in this effect of the DHDO inhibitors. And indeed, we started gene expression experiments that were showing us that there are upregulated and downregulated genes. Among the upregulated genes, we have several types of genes which are involved in the immune response also, but I think that is particularly important. There is also an upregulation of genes which are associated with cell death, as well as in some signaling and so on. But in cell death, in particular, P53 is one of the most important. If we are going just to look at the data of the downregulated genes, which are less with respect to the upregulated genes, indeed we see that most of them are involved in the metabolism of the cells. And this is extremely important because it's telling us also a general picture, which has guided us to see what can be the mechanism. The genes upregulated are more than those downregulated. Genes participating in the hereditary differentiation in the metabolism decline Genes participating in monocyte neutrophil differentiation and movement and apoptosis increase. Induction of a high inflammatory condition in the stem cells environment is observed. Induction of apoptosis and cell cycle arrest through the p53 pathway is the main mechanism of action of the DHODH inhibition, and differentiation is a lesser phenomenon in our hands at least. So we verified this assumption also using CFU assays, showing that indeed there is an increase granulocyte monocyte lineage, but a reduced erythroid commitment of the cells. Also, all the types of amino acids that we investigated in concentration showing a lower degree in the treated cells with respect to what we see in the control, which is, of course, in agreement with what we observed in the end. We know that indeed there is also an induction of the senescence, and this was tested using the beta-galactosidase. Indeed, the senescence, of course, is a growth arrest, then the cells are losing their potential of self-renewal. This is extremely important, and also due. But all these aspects are definitely mediated by an alteration of the mitochondria. Here, by studying the morphology of the mitochondria, what we can observe that the treatment with the DHDOH inhibitor is just a more round mitochondria, enlarged, and also the elongation is shortened. And all the signs of that the mitochondria is suffering from a particular stress. So they are also induced differentiation, as we have seen, also in the gene expression profiling. And our conclusion at the end are that the differentiation effect the DH inhibitors is managed by the metabolic stress. When the action of the DHODH inhibitors is weak, induction of differentiation is the more detectable effect. But when the action of the DHODH inhibitors is strong, the induction of apoptosis becomes prevalent. And finally, we are testing, and this is one of the preliminary experiments, the activity of this compound in vivo. And you may show that in a dose-dependent manner, this is able to inhibit the tumor growth in a CML xenograft model in a very significant way. At least in 2 cases, we also apparently observed the total regression of the tumor mass that was observed at the beginning of the treatment. So the suggested mechanism of action that we have is that on leukemic stem cells, this is the enzymes is leading to the synthesis of orotate, but if we are blocking this enzyme using in the mitochondria using an inhibitor, indeed what we can obtain is just not only decrease of the pyrimidine synthesis, but a decrease of the amino acids, a decrease of the c-MYC expression, an increase of p53, finally leading to a block of the cell growth and increase of the apoptosis. So final slide is, and the most challenging, I would say, aspect is we'll be able to translate this potential of the DHODH inhibition in a clinical useful way to get rid of the CML leukemic stem cells. Who knows? We do not know, unfortunately. But we think that is worthy to be tried, as well as it's important to try also other strategies that can potentially be useful to eradicate leukemic stem cells, because we have now, I think that we all can agree on the fact that the next goal of the CML therapy is represented by TFR and by a definitive cure. I want to thank my collaborators, particularly Mohammed Aushmat, who is a PhD student. Indeed, the work that I presented was the basis for his PhD thesis, and also other contributors in my lab. And I want particularly to thank a great master of mine, but also of all of us, I think, is John Goldman, and his presence after, I would say now, 8 years from his death is still, or we are still missing, John, I think. Thank you very much for your attention.